progesterone because, I mean, obviously their body made it before, so it just doesn't make any sense. But it's like maybe trying a different delivery system. So maybe try a topical, maybe vaginal, oral, I mean, just, and then slowly titrate up the dose. I mean, it's a variety of tricks up the sleeve that your compounder can help you kind of sleuth through that. But it's challenging when they have a hard time with progesterone. Yeah, start lower, and if we're using Prometrium, we're using it compounded. Okay, perfect. Okay, yeah, perfect. All right. All right, well, we'll go ahead and get started with kind of the fun part. Dosing, we're going to talk about application sites and then conversions, because you have these patients that maybe come to you that have been on other delivery methods, and how do we convert them over to a compounded. So we're going to just look at some common doses and preferred routes, and then we're going to be converting from commercial to compounded. So big question. Now that you've learned all of this and you're like, I'm going to go back and I'm going to help my patients, how do I prescribe this? What do I do to get this over to the pharmacy? But first we want to kind of look at some different dosage forms. So not one size fits all. I think patches definitely has a role, but you have patients that have issues with the adhesive, like they're allergic to the adhesive. I love to tell this story about heat transfer. I don't think it's something that the manufacturers thought of. I had a patient, I live in Dallas, and I had a patient that was a semi-pro golfer. And if you've ever been to Dallas in August, it's hotter than Hades. And she came to me and she's like, Sarah, I feel like I put on this patch and then it's just gone. And she was outside in 100-degree weather golfing. I'm like, I started thinking about just, physics and kinetics. And I'm like, I bet you're right. I bet that heat, you're just sucking all of that estrogen out of that patch that first day. And so I don't think patches are great for patients that are super active outside, like, increasing that body heat. They're probably transferring over more hormones than is, designed by the patch. Topical gels typically have alcohol in them. What do we battle with menopause? Dryness, right? Wherever everything is dry, we're lacking estrogen. So I don't love an alcohol gel. Some of the vaginal creams or inserts have propylene glycol in them. A lot of times when pharmacies call in, they're like, oh, this patient had this vaginal prep and they had a reaction to it, like they were all irritated. My very first question is, what wetting agent did you use? Because if they use propylene glycol, that's more than likely the culprit. Well, what's in estrase? Propylene glycol. So people kind of don't realize some of the excipients in some of their products are causing their problems. The drug gets the blame. There are some of the actual just inserts that have lactose in them. To me, that doesn't make any sense. Why are we going to put sugar down there with the bacteria? It just doesn't make any sense to me. So, but some patients do fine with all of that, but I'm kind of biased. Your progesterone capsules that are available commercially have peanut oil in them. Some people have sensitivities to peanut oil or to peanuts. They don't even realize it. There are some products that have dyes people are allergic to, and then it's an immediate release. So you take it and it automatically releases and then it comes back down again. So there's some options that we can do with a slow release capsule. Testosterone, I think Melinda alluded to this, that there's really no FDA approved product for women. The product for men, I can't wrap my head, I've read what NAM says to do, and I just can't wrap my head around how they use just a tiny portion of the androgel. It just doesn't make any sense to me and be accurate. So obviously we can do something with that. Hopefully there will be some commercial products available for women soon. We'll see. And then estriol, there's no FDA approved product for estriol. It is available over the counter in Europe. And they, use it greatly for, preventing urinary tract infections. But we don't have that option here in the States. So even though there are plenty of bioidentical options commercially, sometimes, patients don't fit the mold. And only about 3 to 5% of prescriptions really need to be compounded. And it's not a big deal until you're in that 3 to 5%, right? And you need something special. So your patients have options with RX3 to help them. So routes of administration, obviously we can do oral, capsules, sublingual. I think you guys have a little sample of the RDTs at your site. I strongly suggest there's no drug in them, they assured me. But if you want to see how quickly they dissolve, it's when I started doing RDTs, my sister did my marketing for me, and she like gone in 8 seconds. Well, it probably wasn't 8 seconds, but she was trying to go off the cowboy theme of, buck and bronco sort of thing. But we did that. We would take these offices so that you could see like how quickly it actually is dissolved, much quicker than a troche. A troche is more like a peppermint as far as like the amount of time it takes to dissolve. Obviously, topical, we can do creams, gels. Obviously, there are patches, commercially not compounded. Vaginal creams, gels, vaginal inserts, and then obviously there's the injections, and we talked about the pellets earlier. So those are obviously different dosage forms, not used in compounding sometimes. But what are the most compounded routes of administration? So typically we're going oral, we're going topical, or we're going vaginal. So for oral, typically we're doing progesterone, and Melinda talked about how the metabolites of progesterone orally converting to allopregnanolone that helps with anxiety and depression and sleep, and it can be a beautiful thing for your patients. DHEA can be given orally. I've seen it sublingual as well, but it can be oral. Just for your gentlemen, thinking about clomiphene and anastrozole, those are all oral capsules. We don't do testosterone. I mentioned earlier about the methyl testosterone is meant to help with increased bioavailability of it orally, but I don't love that. And then estrogens, obviously. I said that earlier, like I don't want to do oral estrogen. And this is going into that a little bit more about the venous thromboembolism and how oral estrogen has a prothrombotic effect. And oral but not transdermal. I think we went over this earlier, but transdermal route is really what we want. Oral estradiol, we see that increase in CRP, SHBG. We just definitely want to go transdermal. So oral estrogen has also been shown to increase blood pressure, increase triglycerides, estrone, occurrence of gallstones, liver enzymes. I mean, just on and on and on. What really was the brink of my making this transition to helping with women's health, I remember this one specific patient that came in, and I was working in a compounding pharmacy, and she said, I was getting all my prescriptions from you guys and all of your supplements, and then our insurance changed. So my husband said I had to go to this other provider that was on our insurance, and they changed my hormones to commercial products. I'm sure she was taking it orally. And she said her blood pressure went up. She couldn't sleep. She was depressed. She was all of a sudden she's on all these different medications that she wasn't on before, and finally had the aha moment and said, she probably said some other things, but she said, I'm going to go back to this other physician. I'm going to go back to this pharmacy because I didn't have any of these problems before. So makes me wonder if she was on oral estrogen and caused that increase in her blood pressure as well. So don't want to do oral estrogen, and there's a ton of references listed. If you don't believe me, please don't do oral estrogen. But oral progesterone is great. It is metabolized in the gut and intestinal wall, and it doesn't have a very long half-life. So that's why making a slow-release capsule can be very, very helpful. So like we talked about earlier, the allopregnanolone binds to the GABA receptor, and this just has a very calming effect, very sedative effect. If you talk to your ladies that are start on the oral progesterone, like, oh my gosh, this is the best thing ever. I've always been a great sleeper, and I worried when I went through menopause that I would maybe lose that. And when I got put on progesterone in perimenopause, I was talking to my husband, who's not a pharmacist, not medical at all, and he was like, "What? You don't need any help with sleep?" I'm like, "It's not going to put me in a coma. Don't worry. Like, it's fine. It's fine." But for some ladies, it really makes a huge difference for them. Sometimes when they're in that, and we'll talk about dosing in a second, but sometimes I like to, if they feel great, if we're just doing the 2 weeks out of the month for their cycle with the progesterone, and they're like, oh my gosh, I feel great those 2 weeks, I feel lousy the rest of the time, then we might do a lower dose in the beginning of their cycle, and then increase it towards the end because of this sleeping, because sleep is so important. So again, benefit is sleep, slow release. It's kind of a little semantics. Like we can't say sustained release because we don't have data to show exactly how long we sustain it for. But basically, the pharmacy mixes it with methylcellulose, and that kind of gums it up. And so it's kind of this gummy ball that then the body slowly breaks down. Roughly, according to the studies that Dow Chemical did on their product, on the Methocel, Roughly 8 to 12 hours is what it will last. If someone has very bad GI health, they might not tolerate a slow release. Like that gummy ball might just go right on through. They might not break it down like they need to. So that might be something to file away if you're like, oh, we're on slow release progesterone and she's not having any sort of benefit. Her levels aren't coming up, like nothing's happening. We might need to go with an immediate release as we're working on her gut to heal that. So this was from the Dow Chemical, just showing you had this great long-term effect when we took it, when we added the methylcellulose to it. So it can be dosed at bedtime or it can be twice a day. But typically we'll write SR for slow release or E4M, which is the agent that causes it to slow down. So testosterone can be rapidly absorbed from the GI tract, but it has such fast first-pass metabolism, it really isn't effective orally. I mean, I still sometimes see prescriptions come through. You know, my members will share like, "Oh, the doctor wrote for this." I'm like, "Why are we doing oral testosterone? Like, that's not really doing anything, and we're causing more stress on the liver." But we just don't really recommend doing testosterone orally. You know, the study said that there were high doses that were required to get the daily dose, but then you're, again, stressing out the liver, so I don't recommend that at all. We talked about methyl test and how that is absorbed better orally, but there is liver toxicity, and even when we go really low doses for women, I still don't think it's great. I would much rather do a topical, or my favorite is the sublingual for the testosterone. They did come out with a testosterone undecanate, but it has very low bioavailability as well, and there's GI side effects and increase in blood pressure. So I don't think either one of those are great options. But sublingual, so rapid dissolved tablets, troches, drops, you can do like a sublingual drop underneath the tongue. Anything that we want, you know, any sort of liquid we're putting in the mouth. I like to keep that volume small. So a third, you know, a quarter to a third of a milliliter, a half a milliliter at the very, very most. You start putting a large volume underneath the tongue, it's going to kind of flood, you're going to swallow it, and you might as well just like taking a capsule because you just swallowed the drug. So we want to keep it under the tongue as long as possible. So advantages, avoids the GI tract destruction. You're absorbing it mainly through the mucosal membrane, avoiding the first pass effect. You know, with that rapid dissolved tablets especially, it's a very fast dissolution, quick onset. So doses might need to be done more often. Sometimes taste is an issue. Have anyone ever tasted progesterone? Oh, it doesn't taste great. Yeah, it doesn't taste great. So sometimes that can be a compliance issue. If you're going to be doing saliva testing, that can be a disadvantage because you can't test what's going on in the saliva when you just dissolve something in your mouth. We need to make sure that if we are really wanting it absorbed in the mouth, that our patients know that they don't need to chew and swallow it. You know, they really need to understand how they're supposed to be using it, because if they just chew and swallow it, then it's an oral administration and not sublingual. And sometimes people get tired of waiting for a troche to dissolve and like, oh, just chew, swallow, get it out of there, and they're kind of missing the fact. Topical, one of the most utilized dosage forms of BHRT. I love it that it's easy to adjust, it's easy to apply. We can do it for estrogens, testosterone, progesterone, DHEA. For testosterone, you can add the anastrozole to the testosterone. There's a lot of aromatization that happens in the skin, and so having that anastrozole in with the testosterone topically is a great idea. But there's multiple things we can do with that. Sometimes I get questions about progesterone topical and protecting the endometrium. There have been some studies, not huge studies, but there have been some studies showing that it did protect the endometrium. Sometimes we get pushback on that, because the problem with the why people think that the topical doesn't work is because you don't really get the serum levels, and they think that you need at least a serum of 3.5 to protect the endometrium, and you might not get that, might not see that in the serum with applying it topically. So. But looking at the studies that I've seen, they actually looked at the endometrium itself and didn't see proliferation when they were using topical progesterone. So it can be done. Vaginal administration, good absorption systemically, can be used for systemic or local effects. Again, for estrogen, testosterone, progesterone, DHEA. Obviously there's a lot of documentation for luteal phase defects, so women that are trying to maintain a pregnancy, progesterone vaginal, you're getting the progesterone right there where it needs it. There are commercial products for estrogen and for DHEA, and there is a progesterone as well. But for some ladies, like that's a little messy, right? They don't want that vaginal insert, or they want something small so that they don't have the messiness. Sometimes I have to explain to some of my male counterparts about, when you talk to a woman about a vaginal cream, what's the first thing that we think of? A yeast cream, right? And it's 5 grams and you feel gross, and like just the thought of putting something there on a regular basis, like who wants any part of that? So sometimes we can do smaller inserts, we can do smaller cream volumes, we can do labial administration just right inside the labia where you don't even know that it was there. So there's other ways that we can work around that if we're not getting good results from the topical administration, or they're worried about transference. Transference is also a concern when we rub something on our skin and we're around my sweet little Luca. I wear gloves whenever he's around to apply my cream. You just worry about animals or children, grandchildren getting transference from a topical. So sometimes vaginal is a good way to avoid that. So the different options, creams, gels, inserts, like I said, we can do suppositories. They can also be like just tiny little suppositories, almost like a little dot. Troches, capsules, oral capsules can actually be inserted vaginally. I know it sounds a little weird, but like I used to do a lot of boric acid capsules to help ladies with their vaginal pH. One little trick of the trade is if they pierce both ends of the capsule right before they insert it, that can help water get a little bit faster so that it starts to dissolve, but sometimes it's a little less messy using a capsule. So considerations, preservatives, things that are hypoallergenic, the volume to be inserted. Like I said, we don't want 5 grams of stuff. Petroleum-free, wetting agents. We talked about the propylene glycol. I like to use glycerin as my wetting agent because it tends to be less irritating. Sometimes we do need that wetting agent in order to get that powder to go into that cream base. So I like glycerin for my vaginal preps. And then pH is always a concern. We don't want to do anything that's going to disrupt the pH. So using the appropriate base can commonly mean the difference between success and failure. And, we don't typically think about that. We're like, oh, a hand cream, a cold cream, it's all the same. Well, it really does make a difference as how the hormones are released, how the patient is going to absorb the hormones or the drugs, depending on what base that you're putting it in. So Versa-Base cream, this was kind of our go-to. It's our flagship hormone cream base. We've had it for a really long time. I'm sure there's some samples out there that you guys could feel the different bases. And I encourage you to do that. It's smooth, gentle. You're not going to have the pilling. Sometimes you're rubbing something on and then just kind of like gums up on your hand. You're not going to have any of that. We have several formulas in our database that give RX3 a longer beyond use state, which is helpful for them for workflow, but it's also helpful for your patients because if they want a 3-month supply or 4-month supply, they can get a larger supply and know that the dating is still going to be good within the time frame. So those are very helpful. And then formulated without the things that people are have issues with, and that it can be used topically or vaginal as well. So this is a great base. But talking about how a base is not a base is not a base, that makes a difference. We wanted to study that. So we looked at our Versa-Base, progesterone and Versa-Base cream versus a combo versus one of our other bases, HRT, and then also a Vanny cream. And the Versa-Base cream outperformed all the bases 4 times as much for progesterone. So, at the end of the day, that's what's important, right? How much your patient is absorbing. So we had this study just to kind of show that difference. Elage is one of our newer, it's a vaginal base, and it's anhydrous. And so with some of the regulatory changes that we had, we saw coming up, like if a base was with anhydrous or without water, we could automatically give it a longer beyond use date without one of the extensive studies. And so PCCA got together and was looking at how can we create some bases to make life easier for our members and also for the girls' patients. And so Elage was something that came out for an anhydrous system for vaginal. But with that, we had to okay, well, it's more than just without water. we had to make sure that the hormones were going to be released. We had to make sure that it wasn't going to affect the tissue. One problem that we talk about is leakage. When a woman inserts a vaginal prep, like what kind of leaks out. So these are some of the scientific testing that we did to make sure that we didn't irritate. It didn't leak out. Mucoadhesive, so like it's physically attracted to the mucosa. So when the patient inserts it, it's going to stay in contact with that tissue longer. And then, the problem with something without water, we need to make sure that it emulsified, because with the vaginal fluid. So we have these self-emulsifying properties with the base. So when it's inserted and it mixes with the vaginal fluid, that it starts to release the drug as well. And then we were concerned about what kind of effect would it have on the pH of the vaginal tissue. So those were all tests that we did before we released the product. And this was the leakage study. I'm going to use my pointer. So yeah, I know. Good job, right? Okay, so we had our Elage with a couple different actives, and then we had an over-the-counter product. So just undiluted, just on the tray, there was no change. Everything kind of remained at the top. And then we diluted it because that's like real life, right? We're going to have vaginal fluid, and so you can see that the Elage formulation stayed at the top, and this over-the-counter one just like fell within 10 seconds. So that was our leakage test. So I thought that was pretty cool to say that it's going to stay in place. It's going to stay where it's supposed to once it hits the vaginal fluid. So again, not to leave out our gentlemen, Travis was a base that we designed specifically for men to help with testosterone, absorption of testosterone. So most of the formulations out there commercially have alcohol in them. This is not an alcohol-based gel, and we have different permeation enhancers in there to help really drive that testosterone across the skin, because male skin is different than female skin. So we wanted to make sure that they got good absorption. And this, again, we always kind of back things with research to make sure that we're not just talking, not just saying it, like we have research to back it up. So compared to a competitor base versus alcohol water base, you can see there was much more testosterone that went through the skin versus the other two bases. So we've had great success with this with our members. Okay, so doses. How do we prescribe? Yeah.
I included a hormone form in their folders.
Okay.
Should we bring that out, or are we worried about that?
It's up to you. Yeah, if you want. Yeah, if you want me to.
Just so they can see that
while
you're.
Yeah.
Sorry. So it's on the right-hand side. It says Women's Health at the top. And you'll see it's pretty clear. I'm not going to go into detail right now, but you see the estrogen box, the progesterone box, and the androgen box. We can't write testosterone on the order because somebody gets mad about that. So you have to write it in.
DEA. Yeah, DEA doesn't like that. But I mean, it could be DHEA as well. DEA would be okay if DHEA were on the form, but they're not okay for testosterone to be on the form. So yeah, so we had to not getting anyone in any trouble. Okay, there's no magic hormone combination that can be used for all women. Each woman is individual. Hormone balance is the ultimate goal for all women, but how we get there is very, very different paths for every patient. I always like to look at what do we actually produce? Like how much does our body actually make? Because sometimes we see these crazy high doses and it's like that is not physiological at all. So for estrogen, estradiol, basically 0.07 to 0.5 milligrams is what we'll see, in the phase, depending on the phase of the menstrual cycle. Testosterone production, 0.2 to 0.25 milligrams per day is what most premenopausal women make. Now, what we apply, we're not going to absorb all of that, right? But I think it's always important to have that in our head as to how much we actually do produce. And one of my colleagues is a great chart person, and so she made this great chart of the different phases of the menstrual cycle just to look at how much is typically produced. And then just total daily production rates. Not that long ago, I had someone call in and they wanted like 100 milligram DHEA for a female patient. And I was like, does she want to stay female? Like, what are we trying to do here? Or just even crazy testosterone doses. Like so having this in mind, it kind of helps guide you. And I would always rather someone err on it being too low, as long as the patient knows that this is a process. We're not going to fix this overnight, and then we're just going to gradually taper up to an appropriate dose for that patient. But I love looking at these total amounts. For males, their total daily production, 4 to 10 milligrams. I've seen as much as 15 milligrams, but do they really need 200 milligrams applied? I don't know. We need to really take that into account when we're looking at our dosing. Okay, so we hadn't really gotten into this yet. Typically when I'm giving a talk, this is one of the first things I talked about, but I think Melinda set the stage so well, I thought, well, I'll just talk about the terminology when we talk about dosing. So back when I first started, compounding hormones, we were doing Triest. So it was estriol, estradiol, estrone. And, then things kind of progressed, and then we started just doing the biased estriol and estradiol. Most women make plenty of estrone postmenopausally from their adipose tissue. So unless she's so skinny you can't see her if she turns sideways, probably doesn't need estrone, is kind of what we've learned. But if you look at using my pointer again, look at how these arrows go back and forth. So estradiol and estrone can interconvert, kind of go back and forth to one another. It's not that we left the arrow off to go down to estriol. Estriol is an end product. So it doesn't backtrack. So that's one of the reasons I really like estriol, is because we know that that's where it's going to stay. It's not going to increase estradiol levels or increase estrone levels when we give the estriol. But how do we do these ratios? So when we started and we were doing Triest, we basically did 80% estriol, 10% estradiol, 10% estrone. And then when it was kind of across the board, I was like, I don't know that we need estrone, we just added that other 10% to the estradiol. So most people were doing a biased 80-20. And for the record, even though it's 3 goes before 2, that seems backwards. You always put the estriol amount first and the estradiol amount second, which sometimes it gets confusing. And then over time, I had doctors who were like, can you do a 70-30? Can you do a 60-40? And I was like, I can do whatever concentration you want. And so a lot of doctors wound up landing on a 50-50. And I would think for like the middle part of a bell curve, that's where I recommend most of the time is a 50-50. And the reason is because estriol can be, even though it primarily binds to estrogen receptor beta, it can be kind of competitive with estradiol, which is kind of what we want. Like we want that balance. And so when there's so much estriol on board, I found when we were using the 80-20, I felt like we kept going up and up on the doses because there was just so much estriol kind of keeping the estradiol from getting to the receptor that we needed more estradiol on board to help with their symptoms. Once we started going with a 50-50, I feel like we were able to use those lower doses and patients were doing great. And I would always rather use less than more. But this can be customized. And I said in the middle part of the bell curve, I like the 50-50. If you have a patient that's a little bit older, that's more than 10 years or 15 years postmenopausal, and she's older, I might go heavier. I might do an 80-20, or I might even do a 90-10. I might give her more estriol, just being more conservative. If you have your 30-something-year-old that just had a hysterectomy, I might do a 20-80. Or I might give her more estradiol because that's what her body should be doing at that age. So you have your exceptions on either side. There's times that maybe you just want to go estriol. There's times maybe you just want to go estradiol. I do think having that estriol on board makes sense with how our body normally functions. But the beauty of working with RX3 is this can be customized. If you I had one doctor that did 33-67. Why? I don't know. But I said, sure, doctor, I can make that. So it can be customized. But it really depends on your patients, their lab results, their age, their symptoms, like the exceptions that I was telling you. The time since their estrogen levels have fallen. We need to, again, always replace as soon as we're losing it. But really, to me, the age and kind of what's going on with their history kind of determines kind of which ratio that I use. But The pharmacist can also help you with that if you're like, I'm not really sure which direction to go with this patient. The pharmacist can help you as well. This question has come up because there are some big social media influencers out there that have a pretty big megaphone that like, all we need is estradiol. And not my favorite person, but anyway, we'll leave it at that. So I was getting ready for a talk with a member, and they're like, "Can you talk about why we need estriol?" And I was like, "Yeah, sure." So it's pretty interesting how I said how it can work as an agonist and an antagonist, but I didn't realize that when estrogen binds to the receptor, it binds as a dimer. So you can either have estradiol, 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 estriol, or estriol, estriol. Like two are going to bind to that receptor. And so if it's estradiol, estradiol, it's like very attracted to that receptor and it's going to stay there. It's going to have a longer action. If you have estradiol, estriol, the estriol is going to hit the road sooner. It's not going to bind as strong. And so then that activity is going to decrease. And then if you have estriol, estriol, then estradiol didn't bind. And so it's like even weaker. So I do think it plays kind of a modulatory or balancing act with the estradiol, just like we want to balance our estrogen with progesterone. We want to balance our estrogen with our testosterone. We want to balance our estrogen as well. And so on the form, it says balanced estrogen. And I was like, that's great, Vince. Probably should include estriol and estradiol. So he added that for me, which was great. But it's that dimerization, I think, that really kind of puts it all together. And it was kind of what I had always kind of envisioned in my head as well, as far as the antagonism and agonist. So it's just that equilibrium that it provides. So common strengths and directions, similar to what you have on your forms, but always think optimal dosing. So like we've talked about, whether this, patients are having their symptoms, it can be because their hormones are too high, or it can be because their hormones are too low. The symptoms are going to be exactly the same, and that's what makes it confusing. So finding that optimal dose for them is critical. But start low, go slow, no estrogen by mouth. If the patient is still cycling, I know this is no estrogen if they're still cycling. I think there's like a little caveat, like that's the tricky part. If they are, perimenopausal and they're having erratic cycles, it's just that sputtering of the ovary that makes it difficult as to when to add estrogen. Because if they have this increased bleeding, is it because we had too much estrogen at one point? Or is it because there's something more serious going on? You probably don't have any of these patients, but I had a patient that she fiddled with her hormones every month. And then she would call me to talk to me about what she had done, right? Nobody has patients like that, right? And so she was fiddling with her progesterone and she's like, I still had some spotting. And this went on for a couple of months. And finally I was like, you need to go get an exam. Like someone needs to go check. She had cervical cancer. Yeah. So we were able to catch it in time, but if I continued to let her fiddle, who knows what would have happened. So that's the downside of if we give estrogen in perimenopause is like we're going to make sure that we're really following those patients because all of a sudden they start bleeding or they bleed more. Why? Is it because of the estrogen and their ovaries sputtered about a bunch of estrogen out, or is it because there's something more serious going on? So if we know that they're done, like their FSH has been screaming for several months, then it might be more okay to go ahead and start. That's the tricky part as to how to balance that. If a patient has insomnia, obviously oral progesterone, and then follow up is key. It's not a thanks. Okay, here's your hormones. Move on down the road. It's these patients they need and they want and they are demanding more individualized therapy. They need some hand holding. One thing that sometimes happens is you get that pellet patient or you get that patient that's been on crazy high doses and you see their levels and you're like, and it just makes you want to like freak out. Our inclination is, I want to pull them off of that because that's way too high of a dose. This study shows that could increase their chance of a fatal cardiovascular event. So as much as it freaks us out when we get these patients that have, been increased because nobody ever checked their levels, we have to be slow and try to bring them back down. Number one, we can't pull the rug out from underneath them. Decrease their dose by 25%, maybe every 6 weeks, 8 weeks, just as they can tolerate it. Let those receptors kind of down regulate as we're decreasing the dose. I had a PA come to see me, and she was on 12 milligrams. I'm glad you're all sitting down, of topical estradiol. And yeah, it was a freak out moment. But I said, okay, you realize this is too much. And she was like, I feel great though. And I'm like, okay, well, you're coming to see me, so you realize this is too much. And she said, yes. I'm like, okay. So we slowly, it took us probably 2 years to get her down to a decent level of estradiol. But, if they're willing to work with you and, they came to you on that and you're just trying to help them off of it, we just don't want to go be like, oh, sorry, just deal with the symptoms. We're going to put you on, half a milligram. No, that would be pulling the rug out from underneath, and those receptors would be like, whoa, where did all the estrogen go? So we need to kind of step them down, and it's difficult. It's very difficult. So that's why we start low and go slow, because we don't want those patients, but they wind up seeing you because somebody else didn't do it right. So obviously we've hit on this before about just that time frame between our last kind of regular period to our really last period. That's where things are really, really wonky for our patients. And to me, I think that's the most difficult time in a woman's life. Once we get past that and we can control the hormones that we apply, it's beautiful. I was talking to a pharmacist and she almost seemed depressed that she's like, I said I'm in menopause. And I'm like, it's beautiful. Menopause is beautiful. Like, worry about Aunt Flo coming on your trips. Like, he's just, you're in control of the hormones that we're putting in. Now, if you didn't do hormones, I think that would be terrible, but having hormone replacement makes menopause beautiful. So here, again, my colleague that loves charts put this together. So just, you guys are busy. Like, there's a lot coming at you, and sometimes it's like, oh, where do I start that? This is a great chart for you guys to have as to what's a low dose, what's kind of on the higher end of dosing, kind of where in between. We already talked about the estriol. Like, typically I liked the 0.5 is where I started most of my patients. Progesterone, this is something to kind of point out. So the topical versus the oral are very, very different dosing. And that's because of the first pass effect of the oral. You don't absorb as much of it as you do topically. So we need to basically, if you think, oh, I would prescribe, say, 100 milligrams of prometrium. Divide that by 4. That would be your topical dose, if that's what you're gonna prescribe. Where we sometimes run into these higher and higher doses is they were on 100 milligrams oral, they can't tolerate it, and then it gets prescribed 100 milligrams topical. And then that's, you don't have, it's not the same kinetics as when we take it orally. So making sure that we're making those conversions very, nicely would be great. I have students that come in on their API rotations, and they do a drug information rotation with me, and I had one doing a research on estrogen and insulin resistance. And then she pulled up exactly how estrogen helps, and then how progesterone has the exact opposite effect. And she was blown away by that. And I'm like, yeah, they're meant to balance each other. But this is why I get concerned about patients that are on super high doses of progesterone, is because I think we're going to create more insulin resistance because of the mechanism in the cell that progesterone does to balance out the effect of the estrogen. So again, the oral and the topical are very, very different. Topical testosterone, again, only, or sublingual, only if we have tested to make sure that they're low in testosterone. The last thing we want to do is give a woman testosterone that didn't need it, and she has oily skin, acne, she's unwanted hair, she's going to throw the baby out with the bathwater, and you're never going to get her back. I don't want that stuff. Who wants acne when you're 50? So making sure that they really need it. DHEA, topical, oral. You can also go vaginal as well. That can be helpful. So dosing guidelines for estriol, again, nightly for 2 weeks. I've more recently been thinking that adding an androgen to that is very, very helpful. So adding either testosterone or DHEA. Estrogen does a great job with moisture and the epithelium and the collagen, the elastin, but I think that the androgens really help provide more structure as well. So I've been leaning more towards either adding DHEA or testosterone to recommendations for vaginal. And so just some dosing guidelines for PMS. Typically we're looking at progesterone for these patients. Cyclically, we want to make sure that they have ovulated because we don't want to interfere with ovulation. So depending on, when they've ovulated, technically a 28-day cycle, you'd ovulate on day 14, but nobody's perfect. So maybe they start a few days after ovulation. Or there are some ladies that can tell you when they ovulate. They get the little twinge and they just seem to change in their cervical mucus and they're like, nope, I've ovulated, so they can start the progesterone then. But typically we want to just do it cyclically for these patients. Sounds like a great idea to try to override that cycle, right? Like nobody really loves, well, I take that back. I have had patients that wanted to cycle. I didn't understand it, but I didn't have a cycle for like 13 months after I had my kids, and I was like, this is great. But there are patients that do want to cycle, but we're not going to really override what the body wants to do. And so I think trying to always mimic where we should be, what things should be happening, to me is key. I think Melinda said this earlier when she said moving target. I was like, oh, that's in my slides. I love that because it's that roller coaster. It's a moving target. I don't know that we just do the best that we can to manage the chaos, and especially if they're having like irregular cycles. Sometimes they'll come to you and like, I have no idea what my cycle is. Then they can pick calendar days, or if they know that, well, typically it was towards the end of the month, then we can kind of work with them to kind of come up with what days that they would take it. If they feel great, like I said earlier, if they feel great while they're taking progesterone, and but they're like, I feel lousy the other time, then we're going to do a lower dose. Usually I do like half the dose, days 5 through 11 or 5 through 14 or whatever numbers we're picking. But just I want a few days without progesterone just so we can completely clean house, and then we can start with a lower dose of progesterone and then amp it up mid-cycle so that we can try to mimic what's going on with their cycle. But yeah, it can really make a big difference. Just the sleep in general. So I think we've hit on this pretty hard, but there's receptors all over the body. Women do sleep better on progesterone. There's cardiovascular advantages, and it is protective for brain health. There was a study that came out, it must have been 2 years ago, and the headline said, hormones cause dementia. And I was already scheduled to do a talk for a community pharmacy group talking about hormones in the brain. I'm like, oh, this is perfect. I love this. And so I had my student, I'm like, hey, research this for me. I already knew the answer, but I like research for me. And she comes back, she's like, I had to like dig and dig and dig, and this addendum, finally, they were using all synthetic hormones. I'm like, yeah, I know they were using all synthetic. But that's not what the title said. The title said hormones cause dementia, but we had to look at what hormones they were using. But progesterone is very protective of the brain, so is estrogen. So our menopausal patients, this is when we're adding the estrogen, whether you choose an 80-20, 50-50, or whatever ratio that works for you and your patients. Again, testosterone, we would add that if they are low, but it can make a huge difference for just their overall health. If they're low, just replace that. Like I said, I love the sublingual, like the RDT. For me, I've lost 50 pounds over the last year and a half. And I did not do GLP-1s. I did berberine and started walking like a mad woman, and now I'm running. But when I added, my testosterone had finally dropped where I'm like, maybe we need to replace the testosterone too. It had always been kind of like a number, like not high, not low. And so finally replaced, and it was literally like fuel in the fire. It was like all the hard work I was doing started paying off by adding 0.5 milligram of sublingual testosterone. And so that can make it, because I think I was able to maintain more lean muscle mass, and that helped with my metabolism. That used to be a way I would talk my ladies into testosterone when they needed it, is I would say, well, I think you need testosterone. And like, oh, I don't really have relations. Like, I don't care about that. It's not just about that. And I'm like, how do you feel about losing weight? They're like, what? Tell me more. And I'm like, so the more lean muscle mass, the higher metabolism is. And so we need to increase your lean muscle mass. And then they would be like, oh, tell me more, let's do this. So that could be a way that I talk my patients into it when I know that they really, really needed it. But again, the levels need to be low for us to consider adding that. So just some compounding examples. I always like to start around 0.5 milligram as kind of again, I'm very conservative. In that one case study, I recommended 0.25 just because she was a migraine sufferer. But sometimes we can go ahead and go like 1 milligram per gram, and then they apply 2 clicks, which at the end of this, I'm going to show you one of the clickers. So that can be helpful if especially if they don't have a lot of real estate to rub a cream on. You want to make sure that there's I like a smaller volume. sublingual 0.5 milligram. I started doing RDTs. So like I said, my sister did my marketing for me, and PCCA has an annual conference every year. It's called International, and I couldn't go every year because I was a one-man show, and so if I couldn't go, I sent my sister, who's not a pharmacist, she was my marketer. And she comes back the year they announced the RDT, like all the technology with it. I was like, you need to do this, you need to buy this. And I was like, oh, there's an oven, there's a mold. Like I started like from a business perspective, like looking at all the costs, and I was like, I don't know. She just kept pushing me. I'm like, okay, fine. If I buy this, and you better sell it. You better go out and show doctors about this, whatever. And I'm so glad that she pushed me to do it, because we like helped so many ladies. Because when Oprah was on, I'm dating myself, but when Oprah was on and someone would talk about testosterone, we'd get all these patients come in, they're like, oh my gosh, they'd go to the doctor and say, this is what's wrong with me. I need testosterone because Oprah talked about it. And so I would get the prescription for the cream, and I would refill it once, twice, maybe a third time, and then it was kind of like because I think it's difficult to get testosterone across the skin. And I had one doctor in the Dallas area that labeled himself like a sexual function doctor, and we were doing troches for him. So that's the first person my sister went to. And she's like, try this out with a few patients. He ended up switching every patient from a troche to an RDT. And I was doing all kinds of strengths and flavors. And it was amazing, because these ladies were like, oh my gosh, and we would see their levels come up, and they were like, I feel more like myself, I'm doing my hobbies, I have more energy. Husbands were coming in like, we're getting that prescription, like we're not running out. And so it really, really made a difference for patients. So that's always my preference. I know there's some of my colleagues that are like, oh, I don't know about doing that. I would think a troche is better because it's slower to go across the mucosal membrane. And I'm like, that's not what I saw. In practice, I saw an RDT be great. And I found some literature on a sexual function product that they were trying to come out with that was like, had a testosterone coating around it that they held underneath their tongue, and then they swallowed the rest of the capsule for I can't remember the other medication that was in there. But I was able to see the peaks from that study. So I was like, I think what I was doing was spot on. So that is my preference. Not that troches are bad, but I do think the quick dissolve is better, because I think there's less that you swallow. I tell patients to not eat or drink for 30 minutes after. We don't want to wash away what's in the mouth. And, we're busy. Like, we're trying to get out the door and we might forget. So I just like do a quick little check. Do you still taste it? Then it's probably gone. Like, you're probably good if you didn't pay attention as to what time you threw it in your mouth. So, but 30 minutes is typically good. Vaginal, you can do a biest, or you can do just the estriol. Like I said, add the androgen as well. It could be another great example. So some dosing for male HRT. Now, sublingual, we can do it, but it is such a quick peak and comes back down. I mean, for women as well, but that's typically all that we need. For a guy, they need to basically dose it 3 times a day, maybe even 4 times a day, because they need to maintain that high level. They don't need a quick peak in the morning and come back down. So we're not going to be successful with a once-a-day sublingual for a gentleman. Now, sometimes guys will do a low dose before a workout. They want that quick peak for a workout, or before sexual activity. They want that little peak beforehand. But if we're just replacing their testosterone, it's going to have to be multiple times a day. And I haven't had very many gentlemen that were very successful with that. So a topical probably is a better option for them. And then obviously DHEA could be oral or topical. Like I said, the anastrozole, you can do a lower dose of that either daily or every other day. You can add it to their testosterone topically. That could be sublingual. And then clomiphene for your male patients that maybe still want to maintain fertility and we want to help boost their testosterone levels without overriding it. The last thing we want to do is give testosterone to a young man that maybe he doesn't know he still needs fertility, but he might still need fertility. So we don't want to override that, because the body's really smart. You give it something and it says, thanks, don't need to make that anymore. And so they won't ever start producing more testosterone again. So clomiphene can be a great option. So again, some formula examples. Here's an example of the anastrozole with the topical testosterone, clomiphene, testosterone RDTs. Again, that'd have to be multiple times a day. And you can see the others here. So advantages, ability to add estriol and testosterone to female patients' regimen, more options with progesterone other than 100 milligrams, 200 milligrams. We can make that slow release capsule so you get more steady levels versus the quick peak and the fall down. You can do it transdermally that don't tolerate it orally. or to improve compliance. Not in peanut oil. I don't love the idea of taking peanut oil every single day. Recently, I was talking to someone, and the practitioner was like, "Yeah," or someone asked the practitioner, "Well, do they have a peanut allergy?" She says, "Yeah, she feels terrible every time she takes the Prometrium." You realize there's peanut oil in there, right? Making sure we understand that with our patients, combining. Now, I never like to start out with a combination of all the different hormones into one cream because we just don't really know how the patient's going to respond. Kind of like Melinda was telling us about the pellets. It was all in there, and there was anything that we can do. All those hormones are in one, and they start having symptoms. It's going to be very hard to really fine tune that because we're going to have to raise or lower those hormones together. But I would always tell my patients, my ultimate goal is to figure out what works for you, and then if we can start doing some combination, that can be fewer things that you're applying, and it can be, it can be a cost savings as well. But highly customizable with our compounds, which is great. We can really fine tune it to what each patient needs. So conversions, synthetic to bioidentical. So this is always very, very, very difficult to do, and it's not for the faint of heart. Like it can be a really difficult process. So always consider how long were they on a synthetic. So Premarin for 3 months, not a big deal. 20 years, probably a big deal. Like it's going to be difficult to, a little more difficult the longer that they've been on it. I always liked to try to gradually taper them off of the synthetic. The synthetic's going to sit on the receptor a lot longer than the bioidentical will. But I never really wanted them to refill another prescription of the synthetic if we didn't have to. So I would kind of work with what they had to slowly try to taper them off. And when they weren't using the synthetic, they were using the bioidentical. And so we were kind of spacing that out to where it was maybe an easier step down. A lot of these patients, if they're just on, they had a hysterectomy and they're just on one synthetic estrogen, then they probably weren't on progesterone, right? Because they were seeing a different provider who didn't feel like they needed it because they didn't have a uterus. So that addition of progesterone can also make this process a little bit easier. Estrogen makes progesterone receptors more sensitive to estrogen, and vice versa. Progesterone makes estrogen receptors more sensitive to estrogen. And so adding that progesterone on top of that can make that an easier process. But again, they need to go in fully aware that this is something that they really want to do, and it's going to be a process. It can be done, but just it's going to take some time, and it might be a little bumpy along the way. So patches, this is so confusing. I don't know why in the world they labeled them this way, but they're dosed at in vivo delivery over 24 hours. So not what is in the patch, but what is delivered through the skin, where our compounded creams are prescribed or described as the amount of hormone in each gram or each milliliter. So what we're putting on the skin, not what's getting through the skin. And so it gets confusing when we look at how much we're prescribing for our bioidentical, and this patch is 0.05 milligrams per day. I mean, it seems like we're prescribing a lot higher. So what we want to do is we want to look at how much the patch actually contains. So this one particular example, in the patch itself, it contained 0.78 milligrams of estradiol. It's a twice a week application, so divide that by 3.5. So essentially, on the skin, if it delivered perfectly without 100-degree weather outside, they would typically be getting 0.22 milligrams of estradiol per day is what would be on the skin to go through the skin. We're going to round that a little bit. I just round that to 0.25. We can add the estriol, which I always like to add at a 50-50. And so this patient, if we were transitioning from this patch to a biased, I would recommend a 0.5 milligrams per gram. So it's not really 10 times higher because we're looking at a different area of where the hormones are. So go slow, start low, go slow, meet the patients where they are. So if they are on a patch and we do all the math, right? I love math. I figured out I love algebra. I love ratios. My middle daughter is mechanical engineering, and yeah, I don't love that math. I love algebra. So, but we can do all the math, but then it's like, okay, well, how are they feeling? Are they like, oh, I'm on this patch, but then I have breast tenderness, or on this patch and I'm still having hot flashes? Well, then we probably want to adjust either up or down depending on what's going on with them. But sometimes they come to us and they're like, their levels are high and they're on a high patch. Kind of same thing when the dose is too high. We still want to kind of meet them where they are, maybe just a little bit less, and then just be very gradual, again, to help those receptors downregulate. But each patient is an N of one. That's what personalized medicine is. It's not this, random controlled trial, placebo, blinded, whatever. It's one patient, and that's what we're working with. And we want to look at that entire patient. Look at their adrenals, look at their thyroid, their gut, their detox. I had a patient that was, we were trying to do thyroid for, and she was like 5'9", maybe 110 pounds. Like, she was this tiny, tiny woman. Her TSH was like, I don't know, 20. She couldn't even tolerate the tiniest amount of thyroid. And at the time, I didn't know what I know now about adrenals. And so it was like the adrenals and the thyroid were fighting. And the adrenals were like, oh, you can't boost up the thyroid because I'm struggling over here. And so really looking at all of those components of your patient, especially when something doesn't make sense. Like, why can't you even tolerate just, a microgram of teeth? Like, she couldn't tolerate anything. And it was because her adrenals were struggling. So look at your entire patient, and we can help them there. So real quickly, I wanted to go over, just so you guys kind of understand where RX3 is coming from with the regulatory landscape and what these lovely regulations that we have to deal with. So we still have the black eye from New England compounding from 2012, where fortunately there were several people that died, but this spurred some regulation. So what came out in 2013 was the Drug Quality and Security Act. And basically that kind of defined, are you just a regular, mom and pop pharmacy, regular pharmacy, or are you like a bigger, more manufacturer type pharmacy? And so that's the 503A versus 503B. So 503A, they're regulated by the state boards of pharmacy, and they, work just like they did before. 503B was considered an outsourcing facility, and they are actually regulated by the FDA. And so there's certain things that they can make, and they make things on a large scale, but they have a lot more regulations that they have to abide by because of what happened with the New England. And so, but what they said with 503A is there needs to be either, for us to be able to compound, then it either has to have a USP or NF monograph, it has to be in a commercially available product, or it has to be on this quote unquote bulk substance list or a positive list. I don't know if they will ever finish the PODS list in my lifetime. And I plan to be strong and live a long time, but it's taken a really long time for them to come through, like what's available for this positive list of things that we can compound. And other kind of thing to note is the FDA doesn't consider, and this is something that we're trying to work through with legislation, they don't consider a dietary supplement to be the same thing as a drug supplement. So B12 has a dietary USP supplement, USP monograph, but it's not a drug monograph. And so sometimes there's issues with what we can and can't compound with. And they're like, well, no, it says USP, but FDA doesn't like the dietary supplement section. So here's the bulk substance list that they kind of broke things down. They said category 1, they're like, well, there's enough data, it's safe, it's effective, anything on the category 1 list you can compound with. Category 2, big no-no, can't touch those, they're not safe. Category 3, they're like, well, there's not a safety issue, but we're not sure about the efficacy, and so they can't be an active pharmaceutical ingredient. So you can see it's a long list of category 1. Category 2, there's a lot of the peptides on here. And I know peptide is always a big topic, so we technically cannot compound with the things that are on category 2. Like, that's a big no-no. So we love being creative. We love coming up with solutions, thinking outside the box, but some of these regulations has kind of put a halt on what we can do. So there are limitations. So don't get frustrated if RX3 says, I would love to do that, but I don't know that we can because of regulations. That's when we have to stay active and stay involved and figure out what's going on politically so that we can still take care of our patients, because at the end of the day, that's what we're all concerned with. So with that, thank you very much. And then
So we will take some questions here
Yep.
in a second. But before we did that, I was going to do show and tell. So if any of you can get into these, you've done better than I did. So what happens when you get a full pack of these, you can't see that, this is at the top. and then you can peel it away one unit at a time. But I cut them up so y'all didn't have, anyway, I rendered them impossible to get into. So you can like bend the corner and get into it.
You probably have the top part. You have the top part. Yeah.
So anyway, you can certainly try these. There's no drug in them. They taste really good. If you put it under your tongue or in the buccal cavity, you'll see it takes a good bit of time, but not a huge time for it to dissolve. So that is the RDT.
That's what my sister said. Gone in 8 seconds.
So that is the RDT. And then this is the one that you'll, I don't have any drug in here. So this is called the Uno dose. This is the one we do most commonly for the transdermal estrogen, or progesterone, and testosterone. You should have cream in yours. I don't have it. But each click is, you turn it clockwise.
Yep.
Yep. And you get 0.25 milliliters per click. So if somebody has some cream, so you just put, so I typically put it on like that. I mean, not that I do it, but I do fish. And then you rub it like this, and you can share it to your hips, right? So that's one way typically after you shower or something.
Mm-hmm.
Or you can also
use the clicker itself.
Yeah.
I put the cream on and
Just rub it in, yeah.
Mm-hmm. You just do want to avoid getting it on your hands for transference.
How often do you rotate? Every couple days?
Yeah, every day or so. I mean, I had one patient one time, she brought me this whole picture of like this torso, and she had it all labeled Monday, Tuesday. And I'm like, wow, you need a hobby. Yeah, you need a hobby. Like, that's a little much, but it's like, did I do it here today? I think I'll do it here tomorrow. Like, just a general rotation. Yeah, yes.
And so one click is how much?
0.25. We typically will recommend at least 2 clicks. I'm not 100% sure with this clicker, but another one that we've calibrated, like 0.1 click wasn't as accurate as 2. So it's like if there was a little bit less in the first one, it's going to make it up in the second one. So usually I like at least 2 clicks. Now, if you're having to taper someone down, like, it's not the end of the world if you do 1 click, but it just is a...
Most of the time, it's either 2 clicks or 4 clicks. So don't be doing half.
Right, exactly. Yep.
And also know if you prescribe someone 1 milligram per gram, that's 4 clicks. If they call back and they say, this is just too much cream, it's messy, change it to 2 milligrams per gram and do 2 clicks.
Right. And I do like that smaller volume, you know.
1 ml is a lot.
It's a lot.
1 gram
There's,
is a, yeah,
it's a lot of real estate. Yeah. And most recently, we've been more recommending the buttocks as a great place for absorption. And that was based on a study from patches. Like, they compared the abdomen to the buttocks, and the buttocks had far greater absorption. And also, and then keeping it in a smaller area as well. Like, you wouldn't want to like rub all over the inner arm because of just kinetics. So higher concentration to lower concentration. So if it's in a smaller area, it's higher concentrated and it's going to want to diffuse down, versus in a larger area, it's a less concentration. It's not going to diffuse the same way. So a smaller volume, so like a square like this. Yeah. I always like to do it after a shower, or I wouldn't want to like rub it on and go hop in the pool. Like, I would want to make sure there's at least a few hours from when you applied it to when you were sweating or swimming or showering. As long as like I don't still feel it on there. Like, that's the first thing I do. The first thing I do when I get out of the shower, and then I'm doing everything else before I go in and put my clothes on. So half an hour is usually ideal, but usually you can kind of tell if it's been absorbed. Yeah. Transference, yes. Like I said, I have these garden gloves that I use when I'm around my grandson, and that's what I don't even want it. I don't even want it on my wrist to apply. And I know you can use the applicator. I personally don't like using the applicator. So I'll use the gloves to rub on, because I don't want any of that anywhere near my hands, because there have been cases of, like, I had a vet call me one time, and the vet was like, I need to know what this owner is on, because this dog came in and her vulva is so swollen, it looks like she's in heat. And so the little dog would hop up on the counter, and the lady would apply her stuff and then wipe her hands on the towel, and then the dog would like roll around on the towel and was absorbing enough estrogen that its poor little vulva was swollen. There's been cases of children, being exposed to hormones. We don't think about what we rub on and how we absorb it, but it's easy to transfer. One question that sometimes comes up is vaginal application of estrogen and a male counterpart. I always say, like, if it's a special event, do it after, insert your cream after. But if spur of the moment, it just happens, and it just happens occasionally, not a big deal, especially if it's estriol. But if it's like every night, then maybe you apply, I don't know, like someone's best dream, I guess, for it to be every night. But anyway, then you would want to do it after. But exactly, yeah. But an occasional exposure, I don't think is a huge deal, especially with estriol. And then male transference to females, that is a bigger issue of testosterone. And I definitely have seen that a lot. And just even like using the same towel to wipe off the toothpaste off their face, like there was some transference from that. So if he's applying it in the morning, then he's going to be gone all day at work. You're not going to see him later, then it's probably okay. But looking for other areas to apply it where he's not like going and bear hugging his wife and transferring him. One of my colleagues, she felt like she was getting the transference from their jacuzzi. So because her testosterone went out the roof, and she was, that's the only place I could find that we co-mingled anything was in the hot tub. So anyway, just always kind of keep that in mind. Transference can be a big deal. Yeah.
The other device is called a Pearl. It's a vaginal applicator for a cream. There's a applicator that sticks on the top. Yours might have a pink lid. But yeah, same idea. You stick the applicator, pop it on the top of the device, and then you twist the bottom, and it'll insert the cream into the applicator, and then you can insert the applicator vaginally.
Something to note on these applicators: if you're traveling on an airline, you want to put these in your carry-on. Put them in a cargo load. It can sometimes, the pressure of it can cause it to come out and you have a mess. So at least put it in a Ziploc, so if that happens, you're not stuck, with stuff all over your clothes. But that's
I like it to be on my person in case I lose my luggage. I don't want to be without my estrogen. So yeah.
Supposedly the Uno Dose has some sort of pressurization thing, I think.
Yeah, the Toppy Click seems to be worse for that than the Uno Dose.
And then there is the Micro Click. So I'm most familiar with this with animals for the inside of the ear. I guess you could apply it labially.
Yep,
maybe.
you can. Yep.
I don't know of any other uses.
Yeah, for a small volume like that. Yeah.
In the kit, so you can see them, but each click is 0.1, I think. So
point. Yeah.
Okay, Sarah. So here's a question for you.
Oh yes, ma'am.
So if you have a patient that doesn't like the 2 clicks, can you up the concentration and use the microdose?
That would
for like topical bias.
Yeah, that would be a better option for accuracy. Yeah.
Because that dose is like itsy bitsy.
Yeah, it's just you still need a decent amount of space. Yeah. You need So they probably would need at least 2 clicks of that. Yeah.
Sorry, taking advantage of my expert.
Any more HRT questions?
Sarah, with the advancement of the bases that even we produce at PCA, I wonder, when you have for the women, for the RDP, what about using the Somagna?
Yeah, so we have a sublingual base anhydrous base that we basically designed for semaglutide to have sublingual absorption of semaglutide. Semaglutide is a very high molecular weight drug, and so it's like, okay, well, can we enhance the absorption going through the mucosal membrane? So that was what we designed it for, and we have data showing that we were able to get semaglutide to go through subgingival and suboral tissue, which some of them has a little bit more keratinocytes on top, but we were able to see it go through. We actually even did a rat study, which we'd never really done before, comparing the injectable, the oral, and the sublingual semaglutide and our Submagno. My first question was, how do you get a rat to do a sublingual?
I was thinking the same.
And I was the brave one to ask the question because I guess I'm like the 3-year-old with why. And they said that they were just taking a nice little nap and they pried their little mouth open and they pipetted it under their tongue. No rats were harmed in the study. But it was amazing to look at that data. Obviously, the injectable had the best curve for all of the rats. The oral was all over the place. And even we controlled the fasting time and the amount of water that they consumed before they had the tablet, and it was still very erratic. Where the sublingual, not as great as the injectable, which no one would expect, but it was much more of a closer curve with all of the rats on their absorption. So like with anything that we come out with, our members are very innovative, like your pharmacist here, and members always like, hey, well, could we take that base and do something else with it? And so we have members that are using testosterone and oxytocin and tadalafil and sildenafil. Yeah. Yeah. Yeah, so sublingual. And I know Ernest has another member that was doing a lot of testosterone and having great success with, again, keep that volume small. If I can share anything, make sure it's 0.25 mils, 0.5 at the very, very most, but we want to keep that volume small so it really does sit underneath the tongue and not spill over when we put our tongue down. So, but yeah, it's very sweet. For a gentleman, yeah. For females, it would work for females if they didn't want to do the RDTs, yeah. So yeah, it's and they're the other pharmacies having great results with that too. So just another option. If on the sublingual semaglutide, I don't know if you guys are doing GLP-1s, but sometimes patients need a maintenance dose, and so this could be a great way to do a maintenance dose. Some people are just afraid of needles, and so it's.
It's not full standard injection.
Correct, right.
It can work in certain circumstances, like you said, there have some fetus to needles.
Right.
So it's kind of hit and miss that I've seen so far.
Right. Yeah, we've had members be successful, and it's when it's a whole program. It's a tool in the toolkit. It's not just like you're good. You got to have some hand holding and some other supplements to go along with it. Yeah, so help with their inflammation. Yep. Yep. Oh, good. Oh, good. Well, I'll try to put as much data as I can behind my stuff. So sometimes I know it's a little overwhelming, especially the LDN part. Yes, sir. Yes. So we twice a year we put on an educational event, and providers are welcome to come. So our next one is February, I think 19 through 21. Don't quote me exactly. In Scottsdale, Arizona. And so you can go to pccarx.com. You can search PCCA education, or Chris can give me my email address, whatever. You can email me, and we can get you guys registered for that if you're interested. I'm super excited. One of my talks is, and I think on the website they already have our agenda ready for February, but I'm talking about estrogen and insulin resistance. And I'm super excited. I've just had a little journey with a CGM myself, and realized that my estrogen was low and I was having trouble with my glucose. Once I increased my estrogen, my fasting now is like 93. So, and it was all because that's why I had that student do that project. But anyway, I'm super excited about that. But we always bring new speakers, new ideas, and we're going to have a pre-conference per se. That Wednesday afternoon before the conference starts on Thursday is HRT basics. Last year we had so many new providers that we had a ton of questions during our regular event that were like, I think we might need to offer something. And most people are going to get there the day before anyway. So it's like 2 to 6 the day before so that we can go over some basics so that you can hit the ground running with the full conference on that Thursday. So you can do it virtual as well. Yep. And then we're planning on one in Charlotte in November. So we'll kind of be more on this side of the world, but Scottsdale's nice in February. So, yeah.
Just get with RX3 and give them the information if you're interested.
Yep.
That's actually where I started. I started at HRT Symposium and fell in love with hormones, and that's how I launched into functional medicine training, because some of the speakers that you had at that symposium were the professors in the fellowship. So, yeah, it definitely has changed my life just being connected with PCCA and all the events that they provide. So.
And then we don't have this up on the website yet, but there's going to be a virtual functional medicine conference in July. So, yeah.
That's usually virtual.
That one's going to be, that one's definitely virtual. I think 22nd, 23rd, something like that. But that agenda's not up on the website yet, but be on the lookout for it. That's because we always kind of incorporate functional medicine into our HRT event, but we decided, what if we do a functional medicine, talk about everything but hormones, because we've emphasized the other conferences on hormones. So I'm looking forward to that as well. Yeah.
Sarah, how important is it to counsel your patients when you're doing the dosing, especially if you're getting started? Because I know, like my pharmacy, I'd get a call and I'd say, hey, your refill is due. And they're like, well, it said 2 clicks, I dropped it to 1 because I was feeling this way. And you're like, well, you're not supposed to do that. So how important, because they don't know.
Right.
Patients don't know.
Right.
Because you're messing with the hormones. So how important is it to really get down and deep with them about that?
Yeah, I mean, I think that comes down to counseling from the pharmacy. As providers are so busy, like you can only do so much, but that's where the pharmacy is to emphasize those things. Patients don't really realize, or what drives me crazy is when they, they're going to go in for a test and they're like, oh, I guess I need to stop my hormones for a few days before I go in for a test. And I'm like, you don't have hormones. It's going to be 0. Like, we wanted to see what your levels are on it, So yes, that's definitely all part of the education that, and if they're having symptoms, then they need to be calling. They need to be calling Chris and saying, hey, this is what's going on, or calling your office so that, everyone can make decisions of what needs to happen next versus I just decreased it or I just stopped it, or, but that's where that follow-up is just so key. Because it's a lot, and like Melinda was saying, like it literally is a new phase of your life that no one prepared you for, and it's, you were going through something similar at puberty, and at least you had your mom there to kind of help you, and like now you're like, oh, what do I do? So, yeah. Yes, ma'am.
I have maybe an off-the-wall question, but have you seen either anecdotal or had anyone use LDN for tinnitus?
I recently, not LD, I mean, it makes sense to reduce inflammation. Yeah, it makes sense. I recently, and I jotted myself a note, but I haven't dove into it yet, but methylene blue for tinnitus. Yes, and it's something with the cilia or something. Methylene blue. Are y'all familiar with methylene blue? Yeah. Are you guys doing methylene blue? Y'all are, not a lot of it. I love methylene blue. Like, it is phenomenal of helping support that mitochondria and just the.
So you want to stay for an hour? We'll do a.
I got to talk on methylene blue. Yeah, I know. Vince was like, "How long can you talk for? Can you talk for 5 hours?" I'm like, "I probably can talk for 5 hours."
It wouldn't involve a Krebs cycle.
Yeah, it would involve. Yeah, for sure. And the electron transport chain.
Yes,
Yeah. No, I love methylene blue. I mean, it's amazing, and it's a drug from the 1800s, and they used to pour it in battle wounds, like but phenomenal. Yeah. I was on a Zoom call with another pharmacy, and he had his doctor on, and she was like, it's like I remember where I filed it. And I was like, I need to remember where I filed it. Like, there's a lot up there, and just that recall is just phenomenal. I had that doctor kind of pushed me to want to take it, but then I was trying to think of my middle daughter's prom date. I liked the kid. He was a good kid. I'm like, it's a biblical name. I even pulled up their prom picture, and I'm staring at this kid's name. And of course, my stepmom was like, Matthew, Jonathan, Luke. I was like, stop! Like, stop, you're making it worse. I could not think of that kid's name. It was Elijah, but Eli. I couldn't think of it. Well, then I was like, okay, I need to remember where I felt it. So I started on methylene blue, and probably like a month later, something got brought up about pharmacogenomics. I'm like, oh yeah, Jacob Sweet, student from 3 years ago, he did a talk on that, and I was like, it just literally flew out of my mouth, and I didn't even think about it. And he wasn't even my student, So just that recall, and I think a lot of postmenopausal women could really benefit. Just even when we get our hormones right, sometimes there's yes, and don't buy it on Amazon.
Yeah.
I don't want to know if you're buying it on Amazon. Please don't do that. The toxicity. There's a big difference between industrial, like you would clean your fish tank with, and pharmaceutical. And I don't. They may say that on there, but that scares me. Yeah, you want it from a good source. And then you don't have to worry about a blue tongue or blue teeth if you swallow a capsule. The prescription, yep. So, but yeah, it's phenomenal, and it's a cool party trick. You pee blue or green, depending on your supplement.
What party are you going to?
I don't know. I'm just saying, it's just kind of cool.
She asked the devil.
So I like to start at 5 milligrams. Now there is contraindication with SSRIs or SNRIs. It does increase serotonin. So if someone is on like 20 milligram Paxil, not as worried about starting at that low dose of methylene blue, and we taper off of the SSRI. If there are multiple things that are increasing serotonin, I'm maybe not going to go there. But 5 milligrams, I stopped at 25 milligrams. Again, it's another one of those sweet spot sort of things where you find the right dose for your patient. I have one colleague that if she takes more than 5 milligrams, she feels like she drank a bunch of caffeine. So she can take 5 in the morning, she takes 5 in the afternoon. I can take 25 in the morning. I don't really feel a buzz or anything from it. I just feel like I can think cognitively efficiently. So yeah, start low. There is the G6PD deficiency. So typically males are the expressors of that gene. So females shouldn't be an issue. They might carry the gene. And typically it's more of Middle Eastern, African descent tend to have that deficiency. So you might want to test just to be on the safe side. But so there are a few more precautions with it than it is with LDN. But I think it's phenomenal for a lot of patients. And the studies and the data on Alzheimer's and any sort of neurodegenerative disease is just like literally mind blowing. So yeah, it's fascinating. No, yeah, the gene problem, and then if they're on like massive doses of things that increase serotonin. Serotonin syndrome is obviously not anything to fool around with. But if we taper this up as we're tapering the other down, I did feel a little bit of a serotonin boost when I took it a little bit, but yeah. So. I haven't seen contraindications with that, but I would yeah. And I've had some doctors say that they're not worried about anything with the methylene blue under 50 milligrams of methylene blue. I don't know. I'd rather start low and just taper up to see how people respond. So. Pea and blue, yeah, or green. The party trick, yeah. So, my son started it to help with his cognition and realized that he doesn't always make the toilet. And I'm like, there's markers now of he's 18, and I'm like, son, like in the toilet, I see blue. So, and that's another side effect, I guess, if you have a boy that can't make the toilet. Yeah. All right. Anything else?
I'd like a direct line to you.
Yeah, call Chris. Yeah.
All right, Chris, you want to send everybody? Okay. All right. Well, thank you guys so much. We're grateful to be a part of your care team. You have my number. You should. If not, make sure you get it. We have cards. Well, we have cards out on the table. They might be packed up now, but make sure you get with me if you need my number. You've got the number for the pharmacy for sure. Thank you guys so much.
Yes.
Let's give another round.
FYI, I know this was HRT, but this is just a tip of what Chris can do in compounded mold, just about anything. So besides HRT, there's so many things that they can do. So you have other issues, other things, get with them, and maybe that could be a next topic.
I like to say if you have a drug and a body orifice, a compounding pharmacist can help you get that drug into the body.
Yeah.
So, yeah.
There's a will, there's a way.
That's right.
Yep.
I'm going to their party.
Okay.
Here you go, Vince.